And without further ado, I'd like to welcome Will Martins to the stage.
Thank you for the introduction. I'm Willames Martins. I'm a postdoc here in IOI. And today I will talk about PhageLimp. It's a clinical study that we are conducting in Brazil, basically to try to use bacteriophages as cleaning agents to combat AMR. Initially, I'd like to actually invite all of you to think about how cleaning hospitals in low-middle-income countries is hard. Of course, if you think about here in Europe, the situation is completely different. The hospitals here are clean. But when you don't have a good clean, so probably you have high rates of antimicrobial resistance because poor sanitization, contact between patients, so this is really, really bad. So thinking about that, we thought Klebsiella pneumoniae is one of the main agents causing bloodstream infections and actually all kinds of infections in Brazil, and is associated with high rates of carbapenem resistance. So we thought, okay, if we introduce bacteriophages as natural hunters in the environment, maybe we could try to help the situation because, as I mentioned, phages are natural hunters. So we designed these clinical studies, and basically we have 3 hospitals. Every single hospital we selected 2 intensive care units, and the criteria for these intensive care units was Klebsiella should be a huge problem. So in one of the intensive care units, we will use only a solution without phage, so basically it will be our control. In the second ICU, we will use like a cocktail of phages. So this is a really, really simple way to explain the study, but if we go further, the study has 5 phases. The phase 1, it was almost 8 months, we already did. It's basically we were trying to establish an in vitro assay to prove first that bacteriophages can be stable in hard surfaces. Second, that they can survive even if you put some disinfectants around them. And the third one, we needed to prove that we could clean hard surfaces using bacteriophages. The second phase, so this is the one that we are doing right now, we are running like genomic epidemiology because we needed to understand which Klebsiella we have in every single intensive care unit. Phages are really, really specific. So it's not just about introduce phages, but we needed to know which phages we are introducing. After we have that, we will make like a phage cocktail to move to the third phase where we are doing the intervention. So we are not removing the normal cleaning for the hospitals. We are just introducing phages as an additional step. For the phase 4, we are just checking what happened after the intervention. I can show you here again, but I completely forgot to say that the phase 2 is like 3 months. The phase 3, the intervention is also 3 months, and we will follow up all the infections and colonization in the intensive care unit for extra 6 months. And the final phase is the analysis. As I didn't have time, I just removed the slides about the microbiome study, but we are also running the microbiome studies in every ICU. As results, I will not have time to discuss all of them, so I decided just to put here some highlights for the study right now. I don't have all the results. As I mentioned, we are progressing with the study. This study will finish end of 2025. So for the bacteriophage stability, we were able to notice that even after 10 days, the bacteriophages will be alive. We will be with activity in hard surfaces, which is good for us. So the infection control team, it was really, really important to understand, okay, you are introducing something in our ICU, so how can we clean that? So we were able to prove that if you clean the surfaces with sodium hypochlorite, all the bacteriophages will be dead. However, if you use other type of disinfectants, not exactly. And this step was also really, really good to determine that we are using water to dilute our phages and apply in the intensive care unit. And for the last bit, for the phase 1, we were also able to show that if we use bacteriophages to clean surface, we have a really, really good result. So basically, all the graphs in the left side of this slide basically the first bar is the control, the second one if we spray water, and the third one if we spray a cocktail with bacteriophages. So you can have a reduction of up to 90% of the bacterial load. Just a brief scenario. This is just one hospital because I know that I will not have time to discuss all the hospitals, but this is like the first month of the genomic. I say genomic, but we did the whole genome sequence for all of these strains, but I didn't decide, I didn't put the results here yet. But yeah, the results, they are multi-drug resistant Klebsiella. We already know about that. The most interesting is most of the Klebsiella, they come from rectal swab. So it's also really, really well known that usually critical patients, they colonize first and they have infection after. So this is what we are dealing right now. And to finish this presentation is the sad bit of the study right now. Although we are screening, we are looking for so many phages. So basically, in the top of these slides, they are the first round of phages that we were able to isolate and purify here in Oxford and Central Brazil. And in the right, you have all the Klebsiella strains from the same hospital that I showed you in the previous slide. And if you see the color squares, there are activity against. So the phage has activity against the Klebsiella strain. It's not much. So actually, 30% of the Klebsiella is still without phages, activity against phages. So we are trying to improve that. We expect before to start to make the phage cocktails have this number reduced to below 10%. But yeah, now we are in a phase of collaboration. We are trying to set up a big network with people from Australia, Spain, here in the UK, Leicester, to just get more Klebsiella phages to be able to have activity against all the strains, especially because this is just 1 month. We are running the first surveillance for at least 3 months before we started the intervention. And thank you very much. So many people there. We have so many people and universities involved in this clinical study. And yeah, I just would like to give my big thanks for everybody.